Our next speaker, I'm sorry running slightly late because we started late, is Professor Lil Valentin. Anyone involved or been to any Iota meeting, of course, will know Professor Valentin very well. She was a founder of the Iota project. I remember sitting with Lil having a drink outside the Beganoff Hotel many years ago when we started talking about Iota terms and definitions. And as Dirk said in his introduction, obviously the idea of getting terms and definitions right is a key part of any trial. I think Hanny would talk about staging, or in the old days, when you're comparing trials in oncology, it's essential that you have absolute certainty that you're talking about the same type of tumour. And I think one of the things that used to be ignored was that we weren't doing that with ultrasound. So Lil's going to talk about nomenclature in Iota. We had a discussion yesterday, actually, and I think it was asked at Jeroen Keiser's thesis of whether the nomenclature should be changing or updated, because this was something that we developed some years ago, and whether things perhaps have evolved. So I don't know, maybe Lil may touch on that, and maybe it's something we'll discuss at the end of her talk, but I'll hand over to Lil now. Thank you.
Okay, thank you very much. So I have been asked to discuss with you the Iota terminology, definitions and rules to describe ovarian tumors. So this is the document that I will describe, to discuss with you. This consensus statement called Terms, Definitions and Measurements to Describe the Sonographic Features of Adnexal Tumors, a consensus opinion from the International Ovarian Tumor Analysis Group. This is a consensus statement on how to measure adnexal masses and how to describe ultrasound images of adnexal masses. So why do we need standardized terms, definitions, and measurements? We need standardized terms, definitions, and measurements to understand each other in our daily clinical life. So if I say papillary projection, it should mean the same to you as it means to me. If I say multilocular solid tumor, it should mean the same to you as it means to me. And if I describe the size of a papillary projection, it should mean the same to you as it means to me. That is, measurements must be taken in the same manner, whoever takes the measurement. And of course, without a standardized terminology, it becomes meaningless to compare the results of different studies or to join the results of different studies into a meta-analysis. And of course, if we want to perform multi-center studies, the same terminology and the same measurement technique must be used in all centers. So these are the variables that we use to describe the ultrasound features of an adnexal mass in all our Iota studies. And now I will describe to you how we define the following variables: ovarian lesion, type of tumor, solid component, papillary projection, incomplete septum, shadowing, the echogenicity of cyst fluid, the color score, the ovarian crescent sign, and ASCITES. And I will describe to you how we measure a lesion, how we measure a solid component, how we measure a papillary projection, and how we measure the amount of fluid in the pouch of Douglas. So the Iota definition of a lesion is part of an ovary inconsistent with normal physiology. So for example, this part of this ovary is not consistent with normal physiology. This is a Sertoli Leydig cell tumor. This part of this ovary is not consistent with normal physiology. It is stroma ovari. And this is a lesion because this is a solid tumor filling the whole ovary. This is a hemorrhagic corpus luteum. This is consistent with normal physiology. So this is not a lesion when we use Iota terminology. The Iota definition of a solid component is a structure that has echogenicity suggestive of tissue, such as myometrium or ovarian stroma. And all tissue is potentially vascularized. So this is a solid part of a cystic tumor, and this is a completely solid lesion. The white ball in a dermoid cyst consisting of hair and sebum is not solid tissue. A ball of hair and sebum cannot be vascularized. A blood clot or a lump of mucus is not solid tissue. A lump of mucus or a blood clot cannot be vascularized. Sometimes it is difficult to distinguish a blood clot or a lump of mucus from true solid tissue. Then there are different tricks that we can use. We can push upon the lesion, and sometimes the suspicious structures can then be seen to lift and move away from the cyst wall to swim freely in the cyst fluid. Then we know that this is not true solid tissue. This must be some amorphous material, such as a blood clot or a lump of mucus. And sometimes when we push upon the lesion with our vaginal probe, we can see that the suspicious structure moves in a jelly-like fashion. This is not how solid tissue moves. So we know that this is not true solid tissue. This must be something else, a blood clot or a lump of mucus. Another trick that we can use, if we are uncertain whether a structure is solid tissue or a blood clot or a lump of mucus, is that we can switch on the color Doppler function of our ultrasound system. If we then see vessels inside the suspicious component, we know that this is solid tissue. If we do not detect any color Doppler signals in the suspicious structure, we still don't know, because the reason why we cannot detect color Doppler signals in a suspicious structure could be technical. Maybe our Doppler settings are wrong. Maybe our ultrasound system is not sensitive enough to detect slow velocity blood flow. Maybe the lesion is situated too far away from the probe for it to be possible to detect slow velocity blood flow. Now, after having applied all these tricks, we still feel uncertain. The rule is, if in doubt, classify as solid tissue. The Iota definition of a papillary projection is a protrusion of solid tissue into a cyst cavity with a height of at least 3 millimeters. Using Iota terminology, protrusions with a height less than 3 millimeters are not classified as papillary projections, but as wall irregularities. And of course, a papillary projection is a solid component. This is not a papillary projection because this solid tissue does not protrude into the cyst lumen. The Iota definition of a septum is a thin strand of tissue that runs from one internal cyst surface to another. The Iota definition of an incomplete septum is a strand of tissue that does not reach the opposite wall of the cystic structure in some scanning planes. And incomplete septa are particularly, or they are typical of diseased tubes. Using Iota terminology, there are 5 types of tumor. If you don't know the definitions of these 5 types of tumor, no Iota method will work in your hands. So this is extremely important. A unilocular cyst is a cyst with one cyst locule, no septa, and no solid component. A unilocular solid cyst is a cyst with one cyst locule and one or more solid components. And of course, a papillary projection is a solid component. A multilocular cyst is a cyst with septa, but no solid components. And using Iota terminology, also a bilocular cyst is classified as a multilocular cyst. A multilocular solid tumor is a tumor with tumor with both septa and solid components. And the solid components can be papillary projections or some other type of solid component. And a solid tumor consists of at least 80% solid tissue. Using Iota terminology, there are 5 types of echogenicity of cyst fluid or cyst contents: anechoic, low level, ground glass, hemorrhagic, and mixed. These are examples of shadowing. We can have shadowing behind a ball of hair and sebum in a dermoid cyst. We can have stripy shadows in a fibroma or in a fibrotrichoma. And we can have shadowing behind papillary projections in a serous cyst adenofibroma. The ovarian crescent sign means that the lesion is contained within the ovary. For example, here you can see that this lesion, the Sertoli Leydig cell tumor, is surrounded by normal ovarian tissue. But using Iota terminology, the crescent sign is also present if the lesion is located beside the normal ovary. So, for example, if, as in this case here, you have a para-ovarian cyst beside the normal ovary, then the crescent sign is present when we use Iota terminology. Irregular internal cyst wall is an Iota term that is a little bit confusing because it does not only refer to irregularity of the inner wall of a cyst. It also refers to irregular contour of a solid tumor or in the surface of a solid component. So here, for example, the surface of this solid component here is irregular, so the criteria of irregular internal cyst wall are fulfilled. Using Iota terminology, ascites is defined as fluid outside the pouch of Douglas. This means that if there is no fluid in the pouch of Douglas, but you have fluid between the uterus and the urinary bladder, for example, using Iota terminology, this is classified as ascites. The Iota color score is based on subjective evaluation of the color content of the tumor scan. A color score of 1 means that there are no color Doppler signals detectable in the tumor. A color score of 2, that there is a minimal amount of color Doppler signals detectable. A color score of 3, that there is a moderate amount of color Doppler signals detectable. And a color score of 4, that there is abundant color Doppler signals detectable in the tumor. And of course, when you assess, when you estimate the color content of a tumor scan, it is extremely important that your Doppler settings are correct. You must adjust your settings to maximize detection of slow velocity blood flow without artifacts. So usually in most ultrasound systems, the optimal setting is 3 to 6 centimeter per second velocity scale. And then you increase your gain until you see artifacts coming, and then you decrease your gain just until you see the artifacts disappear. Measurements. How do we take measurements using the standardized Iota examination technique? We should always measure 3 orthogonal diameters. And we measure a lesion, an ovary, or a solid component where they appear to be at their largest. So for example, if you want to measure the size of a lesion, you first obtain a sagittal section through the lesion where the lesion appears to be at its largest, and then you measure the length and the anterior-posterior diameter of the lesion. Then you turn your transducer 90 degrees to obtain a transverse section through the same lesion, and you measure the width of that lesion, where the lesion appears to be at its widest. How do we measure a papillary projection? Using Iota terminology and using the Iota models, we should always measure the largest papillary projection. We measure 3 orthogonal diameters, and when we measure the height of the papillary projection, it is very important not to include the thickness of the wall or the septum from which the papillary projection arises in the measurement. How do we measure the amount of fluid in the pouch of Douglas? We measure it on a sagittal scan through the pelvis, and we report the largest anterior-posterior diameter of the amount of fluid. So now I have described to you the variables that we use in the Iota models, and Dirk has already, and I have told you also how we take measurements of a lesion, a solid component, a papillary projection, and the amount of fluid in the pouch of Douglas. And Dirk has already told you that these are the variables that we use in the Iota models LR1 and LR2. We use these models to calculate the risk of malignancy in an adnexal mass, and a risk above 10% classifies the mass as malignant. And of course, if you don't know the definitions of the variables in the models will not work well in your hands. You must use the Iota definitions of the terms. And these are the variables that we use in the adnex model: the maximal diameter of the lesion, the maximal diameter of the largest solid component, more than 10 cyst locules, the number of papillary projections, acoustic shadowing, and ascites. And for the model to work, you must use the Iota definitions of all these variables. Now, some of you might prefer not to use a mathematical model, but to use something simpler, for example, the Iota simple rules. If you use the Iota simple rules, there are 10 malignant ultrasound features and 10 benign ultrasound features. You look for these features and you tick the features that are present, either on a paper form or in your Iota app on your iPhone or on your iPad or on your computer. And if there is at least one malignant feature, no benign feature, the mass is classified as malignant. If there is at least one benign feature, but no malignant feature, the mass is classified as benign. If there are both malignant and benign features, or if none of the 10 features is present, the mass cannot be classified using the simple rules. So these are the 5 malignant features: irregular solid tumor, presence of ascites, at least 4 papillary projections, an irregular multilocular solid tumor with the largest diameter of at least 100 millimeters, and abundant vascularization at color Doppler. These are the 5 benign features: a unilocular cyst, and please remember the definition of unilocular cyst. The largest solid component has a largest diameter less than 7 millimeters. There is shadowing, or the tumor is a smooth multilocular tumor with the largest diameter less than 100 millimeters. And at color Doppler, there are no detectable color Doppler signals. So, now I have discussed with you the definitions of the variables that we use in the Iota mathematical models, and I have discussed with you the 10 ultrasound features that we use in the Iota simple rules. So, any questions?
Indeed, any questions, basically? Any from the floor? Is it all totally clear? I mean, the obvious question, I think, is, do you think that these definitions are still fit for purpose many years on? Because remember, we sort of sat down and made these definitions of what we felt were reasonable ways of moving forward. But now, after the experience of the studies and looking at the data, do you think that anything should be revised, or should we be adding anything in now at all?
I think it is very difficult. I mean, to change the definitions, because our models are based on these definitions. So I think it would be inappropriate to change the definitions, even if we might feel that some of the definitions should be changed. It wouldn't be appropriate, because the models are all based on these definitions. So I don't think we can change them. One could, of course, contemplate adding other variables, but that would be a completely new model then.
I mean, one of the things which I think we always had concerns about was, I mean, the colour score seems to work, but it's pretty crude, isn't it? I know you've looked a lot at tumour vascularity. I've always, you know, I mean, as you know, I looked at Doppler quite early on. I've always been frustrated by the fact that we've never quite seemed to have captured the information that is probably there. But I think you've looked at it quite carefully and found it's useful, but it's marginal. Is that fair to say? You're looking at tumour branching, looking at things like that. And whether we can get more information out of the colour or out of the vascularity of tumours. Do you have any views on that?
Is your question whether looking at the vessel morphology could add some information to simply estimating?
And if so, could that be another variable, or should we be defining it and adding it into our...
Yeah. So looking at vessel morphology, we can do that using 3D ultrasound, and maybe some of you attended one of the roundtable sessions this morning. It is quite a tedious procedure, actually, to do that. There is information in the morphology of the vessels seen in a 3D ultrasound image of the vessel tree. It doesn't add very much in an ordinary tumor population. The question is if it could help us in the small group of tumors that experts find very difficult to classify as benign or malignant. And we have found that it adds something, but not dramatically much, I must say.
Are there any questions from the floor? I mean, one thing I think, I mean, talking about definitions, I just wondered if you wanted to comment on our definition of malignancy, i.e., because you raised this issue of 10% defining whether something is cancer or not. And I've always wondered whether that's actually rather a high cutoff.
Well, I mean, you have seen the results. If you use that cutoff, you detect 96% of the malignancies, and still your false positive rate is less than 10%. So it's a very good balance between sensitivity and specificity if you use the 10% risk cutoff. Even if to a woman or even a doctor, 10% risk might seem very high, but it works. I mean, it works in clinical practice to divide your people into... No,
I just was trying to illustrate the point, really, because I think it's this issue of risk and actually test performance, if you know what I mean, which is what you've just illustrated. You can detect most of the cancers at a 10% risk.
Yeah.
Okay, Lil, I think that's, we have to close there. Thanks very much. I think that's a really important talk. We are obviously running slightly late, but actually now only 6 minutes, so we're not so bad. So I would suggest that we break for coffee and come back at the appointed time. Which is 11:15, and we'll start promptly then. Thanks very much to all our speakers and to all the audience. Thank you.